So if you break an arm, right, an X-ray gives you this really clean, objective answer.
Yeah, it's totally binary.
Exactly. I mean, you look at the film, you see the jagged white line, and the doctor basically points to it, says, well, there is your problem.
Right, it's visible. And honestly, it's comforting to know exactly what you're dealing with.
It is. But then you take an X-ray of someone who has been just, absolutely crippled by the loss of a loved one, and you see nothing.
Nothing at all.
Yeah. And for the longest time, we've treated the landscape of human loss as something, I don't know, poetic and murky. Essentially just telling people they just need to give it time.
Which is incredibly frustrating.
Right. But today, we're exploring some groundbreaking clinical guidelines that finally provide an X-ray for a broken heart.
I really like that analogy.
Thanks.
Yep.
So, okay, let's unpack this. The core revelation we are looking at today in this deep dive is that while grief is an absolutely universal human experience for you and me and everyone, there is a very specific treatable state where grief acts like a mechanical failure.
Right, where it literally praps a person.
Yes, and medical science has officially given it a name.
And we are looking at a fundamental shift in how the medical community understands mourning here.
A huge shift.
The goal of this deep dive is to completely strip away that incredibly damaging societal stigma of someone, taking too long to grieve.
Yeah, that judgment people get.
Exactly. When we dive into these clinical guidelines, we are moving entirely away from the philosophical descriptions of sorrow. We are looking at the concrete, neurological, and psychological reality of what happens when the human brain gets stuck in this perpetual loop of acute loss.
Because the narrative for decades, or maybe centuries, has just been that grief is a feeling you have to endure.
Right, just push through it.
Yeah, you experience a profound loss, you wear black, people bring you casseroles, you cry, and eventually time heals the wound. You are expected to move on.
That's the societal expectation, yeah.
But these new guidelines completely shatter the time heals all wounds expectation, don't they?
They dismantle it completely. So in 2022, a massive update occurred in the psychiatric world.
Okay.
The Definitive Diagnostic Manual for Mental Health Professionals, which clinicians refer to as the DSM-5-TR, officially added a brand new diagnosis.
Wait, really? A totally new diagnosis just for grief?
Yes, it's called prolonged grief disorder, or PGD. And this edition provides clinical validation that something mechanical in the brain's processing center has basically stalled.
I want to make sure we are incredibly clear on this right out of the gate for everyone listening. Prolonged grief disorder is explicitly not the same thing as just normal grief.
Not at all.
Like, we aren't just slapping a medical label on someone who's feeling very sad.
Oh, it is entirely distinct. It's not about the depth of the sadness. Anyone grieving is deeply sad. It's about the mechanics of how the brain integrates a new reality.
How so?
Well, when someone is experiencing PGD, their psychological processing has essentially hit a brick wall. They are unable to integrate the reality of the loss into their ongoing life narrative.
Oh, wow.
The brain is treating the death as if it just happened yesterday, every single day.
That sounds exhausting.
Yeah.
So think of it like a physical wound. If normal grief is a deep, severe laceration, it bleeds, it hurts terribly, it requires intense care.
Right.
But over time, your body's immune system kicks in. The healing process begins. It's going to leave a permanent, visible scar, and that part of your body might always ache a little when it rains, but eventually the tissue binds together and you can actually move again.
That is a great way to look at it.
PGD, on the other hand, is like a wound that remains actively infected.
Yes.
The natural immune response fails, the healing process completely halts, and the active infection prevents the person from functioning at all.
Exactly. The brain is quite literally stuck.
But grief is so subjective.
Yeah.
If I'm crying every day for a month, am I stuck or am I just deeply sad? What is the actual, mathematical formula clinicians are using to measure this boundary between a profound loss and a clinical disorder?
Well, the clinical metrics are actually quite rigid now. The core engine driving prolonged grief disorder is a persistent, intense yearning for the deceased, combined with an all-consuming preoccupation with the death.
Okay, so it's more than just missing them.
Oh, it completely transcends simply missing someone. It manifests as a total inability to focus on almost anything else in the present moment.
Wow.
And alongside that core yearning, clinicians look for a specific threshold of secondary symptoms. A person must exhibit at least 3 out of 8 specific markers.
3 out of 8. What do those markers actually look like in a patient?
Well, they include a profound, lingering sense of disbelief that the death even occurred.
Okay.
Intense emotional pain, and active avoidance of any reminders of the person who died, immense difficulty reintegrating into daily life, feeling emotionally numb to the world.
Numbness. Yeah, that makes sense.
Right, and feeling that life is now completely meaningless and experiencing intense, isolating loneliness.
I want to pause on one of those symptoms, actually, because the phrasing used by the clinicians in the source really stopped me in my tracks.
Which one?
They call it identity disruption. The official clinical marker is literally defined by the patient feeling like a part of me died.
Yes, the literal phrasing.
We hear that phrase in movies or in poetry all the time, right? Like, a piece of me died with them. But to realize that psychiatrists are using that exact literal phrasing as a measurable medical symptom, I mean, that is wild to me.
It really highlights the severity.
It implies that our identities aren't just, housed inside our own heads.
What's fascinating here is how deeply our neural pathways map our existence in relation to the people around us.
Neural pathways.
Yeah, your brain literally constructs your sense of self through your interactions, your shared routines, and your emotional bonds with a loved one.
Oh, wow. Okay.
When they are suddenly gone, that intricate neural map is just rendered blank.
That is a terrifying thought.
Yeah, it is. And for someone navigating typical grief, the brain slowly and painfully begins to draw a new map. But for someone with PGD, the brain absolutely refuses to draw a new map. It keeps trying to navigate a landscape that simply no longer exists.
Which brings up the issue of time. Because if your map is suddenly erased, you obviously wouldn't expect anyone to just draw a new one in a few weeks.
No, absolutely not.
You wouldn't diagnose this 2 weeks after a funeral.
Right. The timeline is a crucial diagnostic factor. For adults, this intense paralyzed state must persist for at least 12 months after the loss, before a diagnosis of PGD can even be made.
12 full months.
Yes. And it must also significantly impair their daily functioning, meaning they can't maintain their employment, they completely withdraw from surviving relationships, or they basically neglect their own basic care.
Right.
But crucially, for children, the timeline is much shorter. The clinical threshold for a child is only 6 months.
6 months for kids. That is a radically short window when you're talking about the loss of a parent or a
It
sibling.
really is.
It underscores how incredibly vulnerable a developing brain is to getting locked into these trauma loops.
Exactly. It speaks directly to neuroplasticity. A child's understanding of the world is forming so rapidly that a traumatic loss can cement itself into their foundational architecture much faster than an adult.
Because an adult's worldview is already somewhat stabilized.
Precisely.
So if we have these concrete timelines, 12 months for adults, 6 months for kids, how common is this active infection? I mean, almost everyone listening to this right now will experience a significant loss at some point in their lives.
The research indicates that roughly 7 to 10% of bereaved adults will actually develop prolonged grief disorder.
7 to 10%. That is a staggering number of people walking around with an active invisible condition.
It's a huge portion of the population.
Are there certain circumstances or, types of loss that overload the system and make that 7 to 10% more likely?
If we connect this to the bigger picture, you start to see why that prevalence rate exists. The brain's natural processing ability gets short-circuited by extreme circumstances.
Like what?
Well, we see heavily elevated rates of PGD following deaths that are sudden, traumatic, or violent, the loss of a child, a suicide loss, and interestingly, a massive spike in PGD following a very long period of caregiving.
Oh, well.
And we are also tracking a significant rise related to the unique isolation of pandemic losses.
Wait, that caregiving trigger is honestly counterintuitive to me.
How so?
Well, you would assume that if someone has been caring for a terminally ill spouse or parent for, say, 5 years, they might be more psychologically prepared for the end, like they saw it coming.
You might assume that, sure. But consider the identity disruption we just discussed. When you are a full-time caregiver for years, your entire identity, your sleep schedule, your daily routine, and your primary purpose become completely fused with keeping that other person alive.
Oh, man. Yeah, I see what you mean.
When they pass away, you don't just lose your loved one. You lose your job, your routine, and your fundamental reason for waking up in the morning.
The entire map is gone.
Exactly. The brain's entire operating system is suddenly obsolete, and the system just completely freezes.
Okay, so this brings us to the most urgent question. If you are listening to this and you are recognizing these symptoms in yourself, or maybe you are watching a friend experience this intense identity disruption 14 months after a loss,
Yeah.
how do they actually get unstuck?
The incredible news here is that because the psychiatric community finally understands the specific mechanics of PGD, they have developed highly targeted tools to fix it.
That's amazing.
The very first step is identification. Clinicians now use a validated screening instrument. It's essentially a highly specific 13-question clinical tool called the PG13R, designed to pinpoint this exact disorder.
Here's where it gets really interesting to me. Having a concrete, validated questionnaire for something as historically abstract as grief.
It changes everything.
Think about how empowering that is. If you are drowning in sorrow and you think you are just weak, or you think you are quite literally losing your mind, a clinician can hand you this questionnaire and say, look at your score. You aren't weak. You have a known, measurable condition.
Yes.
It turns a subjective nightmare into a tangible, treatable reality.
Naming a condition is always the first step in dismantling its power over a patient. Once it's identified, the treatments are highly specific. The clinical guidelines highlight specialized therapies, such as complicated grief treatment.
Right, pioneered by Dr. Catherine Shear. I saw that in the notes.
Exactly. Dr. Shear's work is foundational. There is also grief-focused cognitive behavioral therapy.
But wait, why specialized therapies? If someone is completely paralyzed by sadness, why wouldn't standard depression medication or just, general supportive talk therapy work? Isn't grief just a severe form of depression?
This raises an important question, and it's a vital distinction for anyone seeking help right now. The root mechanism of PGD is uniquely different from clinical depression.
How are they different?
Depression is generally characterized by a pervasive, generalized loss of interest in life, low self-worth, and an inward-facing sadness. PGD is completely different.
Okay.
It is characterized by intense yearning. The focus is entirely outward, fixated almost obsessively on the missing person.
So treating PGD with depression tools is like, I don't know, using the wrong wrench on an engine block.
Exactly that. You aren't fixing the problem, and you might cause more damage. Furthermore, general unstructured talk therapy can sometimes inadvertently reinforce the destructive loop.
Wait, really? Going to therapy can make it worse.
If it's the wrong kind, yes. If a patient just comes in every week and talks endlessly about how much they miss the person, they might just be deepening the neural pathway of yearning.
Oh, that makes total sense. They're just practicing the yearning.
Exactly. Dr. Shear's complicated grief treatment, by contrast, is highly structured and active. It gently but firmly forces the brain to process the reality of the loss.
What does that look like in practice?
It tackles those avoidance behaviors head-on, like a patient who refuses to look at photographs or walk past a certain room in their house. The therapy actively guides the person to face those triggers and rebuild a sense of purpose.
It's basically physical therapy for the brain.
That is a perfect analogy.
You can't just rest an injured knee forever and expect it to heal, right?
Yeah.
You actually have to do specific, targeted, often painful exercises to break up the scar tissue, rebuild the muscle, and restore joint flexibility.
You have to actively rehabilitate those psychological pathways. It takes work.
It's incredible that we have the clinical blueprint to actually do that. But I do want to push back a little on how this plays out in the real world.
Sure, let's talk about it.
Knowing about specialized grief therapy is fantastic in theory.
Yeah.
But if the primary symptom of prolonged grief disorder is avoidance, literally an inability to even get out of bed, a terror of reintegrating into daily life,
Right.
how do you get that paralyzed person to shower, drive across town, and sit in a crowded clinical waiting room? The actual logistics of getting the treatment seem to trigger the exact symptoms of the disorder.
It's a huge paradox.
And even if they could drive there, how many people actually live down the street from a specialized grief clinic?
That paradox is the major real-world hurdle in treating PGD. The traditional therapy model often demands too much functioning from a patient who literally cannot function.
Exactly.
That is why the clinical notes we are reviewing highlight the Coping and Healing Counseling Model, or CHC, as a vital case study in bridging this gap.
Oh, okay.
They have engineered a delivery system that specifically bypasses the roadblocks of PGD.
Let's look at how they bypass those roadblocks, because when I look at the CAC model, what stands out is that they operate on a 100% telehealth framework.
Yes, completely virtual.
Now, initially, I was pretty skeptical of this. We were talking about the most profound, devastating emotional pain a human can experience. Doesn't a patient need to be in a physical room, handing the therapist a tissue?
That's the traditional view.
Right. Does doing this over a computer screen or a phone really diminish the deep emotional work required to process grief?
It's a very natural skepticism to have. We are heavily conditioned to think therapy absolutely requires a physical couch. But when you look at the avoidance symptoms of PGD we just discussed, the 100% telehealth model actually serves a profound, counterintuitive clinical purpose.
How so?
By completely eliminating the waiting room, the commute, and the public exposure, you remove the initial barrier to entry. The patient can begin this terrifying, heavy emotional work from the absolute safety of their own home.
Oh, wow. I hadn't thought of it like that.
They can literally be in their pajamas. They don't have to face the outside world until the therapy actually begins to work, and they are genuinely ready.
Ah, I see. So you are meeting the patient exactly where they are stuck. You bypass the avoidance trigger entirely.
Precisely.
And by doing it purely through telehealth, they are able to serve a massive geographic area. The CHC guidelines note that they cover all 159 counties in the state of Georgia.
Which is huge for accessibility.
Yeah, they are reaching dense urban centers like Atlanta, but equally important, they are reaching remote rural communities where specialized clinical social workers and licensed therapists are essentially non-existent.
Geographic isolation is a massive compounding factor in prolonged grief. Providing a highly diverse, culturally competent team of specialists who can reach a patient anywhere in the state is honestly revolutionary.
And they treat more than just individual adults, right?
Right. They are equipped to handle individual therapy, couples navigating the strain of a loss, and crucial family and teen therapy for anyone 13 and older. And they are treating not just the grief, but the secondary anxiety, depression, and trauma that almost always accompany it.
But another roadblock is just finding the patients before it's too late. When someone is grieving, they usually aren't, researching specialized clinical frameworks online.
No, they're usually just trying to survive the day.
Right, so what's fascinating about the CHC model is that they aren't just waiting for the phone to ring. They have built system integrations directly with hospice centers, palliative care, and primary care physicians.
This is a critical structural innovation. Think about the timeline again. By coordinating directly with end-of-life care providers, CHC is creating a proactive safety net.
So they are catching people early.
Yes, they are catching the surviving family members early on, providing that culturally competent support before the 12-month mark, before the grief calcifies into a disorder, and long before the patient falls completely through the cracks of the healthcare system.
That makes so much sense.
They treat grief care as an essential, integrated step in the standard end-of-life care continuum, not just some afterthought.
And of course, specialized therapy is entirely useless if it bankrupts the patient. Financial stress compounding on top of profound grief is an absolute recipe for disaster.
It happens all too often.
What really stands out in the CFC model is how they have systematically dismantled the financial roadblock as well. By completely eliminating copays for Medicaid patients, they are providing transformative access to lower-income populations who often experience the most compounding traumas.
It's vital access.
And for those with major commercial insurance, they keep the out-of-pocket costs incredibly low, generally between $0 and $40 a session. So they've removed the geographic barrier, removed the avoidance barrier, and removes the financial barrier.
It really acts as a blueprint for how this specialized psychiatric care must be delivered if we are actually going to reduce that 7 to 10% prevalence rate.
Absolutely.
And if anyone listening wants to see exactly how this model operates, the contact information provided in the case study is incredibly straightforward.
Yeah, let's share that.
They can be reached by phone at 404-832-0102 or online at cheektherapy.com, and their support email is support@cheektherapy.com. It basically takes the abstract clinical victory of identifying PGD and translates it into an accessible, real-world lifeline.
So what does this all mean? If we zoom out and look at everything we've unpacked today, we started with the concept of the broken bone versus the broken heart.
Right.
The key clinical message we are walking away with is that prolonged grief disorder is a real, scientifically recognized medical condition. It's an active infection of the mind's ability to process reality.
It is not a moral failing.
Exactly. If you are stuck, you are not weak. You are not failing at grieving. You have a condition that has evidence-based, highly specific treatments. And most importantly, seeking help through specialized targeted therapy isn't a sign of forgetting your loved one or moving on without them.
Quite the opposite.
Yeah, it is the exact proven path back to a meaningful life that actually honors the person who was lost.
I want to speak directly to you, the listener, right now. Whether you are a student prepping for a psychology exam, a healthcare professional trying to catch up on the latest clinical trends, or perhaps someone who's currently navigating a devastating loss yourself. Understanding the mechanics of PGD, recognizing that profound identity disruption, that relentless outward yearning, and understanding the timelines, this knowledge is immensely powerful.
It really is.
It can quite literally save a life. It changes the entire cultural conversation from just give it time to let's get the right kind of specialized help.
It replaces judgment with actionable tools. But as we wrap up this deep dive, there's one detail from the clinical criteria we discussed earlier that I honestly can't quite shake. Something
Oh,
for you to ponder on your own as you go about your day. We talked about those rigid diagnostic timelines. If the clinical threshold for prolonged grief disorder requires 12 months of being stuck for an adult, but only 6 months for a child, it forces us to wonder,
yeah.
how much faster does a child's psychological framework solidify around a traumatic loss compared to ours? And what does that incredibly short 6-month window mean for how hypervigilant we need to be when we are supporting the grieving kids in our own lives?
It's a sobering thought.
If an adult's emotional x-ray shows a wound that takes a year to calcify into a disorder, a child's takes only half that time. The window to help them is terrifyingly brief. We absolutely have to be paying attention. Thank you so much for joining us on this deep dive. We'll catch you next time.